Hi, everyone. Barbara Wirostko. I am an adjunct professor at the University of Utah, and I'm going to be speaking to you about home monitoring and actually some real cases that have helped me manage my patients better. And thank you to the iCare team for inviting me. I've been working closely with them now over the last few years. Love their technology. They have given me an honorarium to speak to you today. And I also do have some other disclosures that are unrelated, except for my eyes, which helps provide the iCare tool to patients. So what do we know about glaucoma? If you're standing here, you obviously are very familiar with glaucoma. And IOP is the only modifiable risk factor. It's a slowly progressive optic neuropathy. And we know that if we lower IOP, we actually slow down disease progression. But the studies have also shown us that a lot of times, even despite IOP lowering, and we know in our own practice that patients still progress. What's been really nice is more and more in the guidelines, both in Europe and in the OD community, MD community, and with the American Academy, is that we are recognizing that IOP fluctuation is an important risk factor and affects progression. But up till now, we have not been able to easily and adequately look for that IOP fluctuation over time, except a few time points in the office. And when you think about how we diagnose, we always talk about what is the max IOP. IOP fluctuation, as I said, is an independent risk factor. There are other risk factors that are playing a role. But again, progression can occur even when IOP is controlled. So what are we missing? Over the last 5 years, I found that I'm probably missing the pattern and the variability of IOP fluctuation in my patients, especially in the early waking hours. The other thing that's interesting, too, to call out is our SIGIT study, which was our 9-year study before we even had a home monitoring device. They found that despite baseline IOP, the delta, or the amount of variability during the clinic, was directly linked to IOP variability and glaucoma progression. So that's really powerful. So think about that. Mean IOP was not as important as that delta, and the delta happened to be 8.5 millimeters of mercury. And I'm going to call out some cases. So why is IOP in the office not enough? And I always go back to how are we monitoring blood pressure patients and, more importantly, diabetics? It's a physiologic marker. IOP is a surrogate for disease. It's a risk factor for disease, but yet we're treating a potentially blinding disease on one measurement every 6 months or every 3 months. And again, it just seems so backwards to me. We want to control variability. We want to reduce the fluctuation on that optic nerve head and really slow down progression. And I really go back to what are other chronic diseases doing and how have they moved forward? And they're doing home monitoring. They're empowering the patient. With IOP fluctuations and spikes, the studies have now shown that they occur in the early waking hours. And then more importantly, with rebound tonometry, there's numerous studies in the literature that actually show that it correlates very well with Goldman tonometry. And I always come back to the fact that we call Goldman tonometry the gold standard. And is it really? It is it's even more variable and more noisy when you think about the measurements and how we actually measure Goldman. So the value of home tonometry to me originally started as a diagnostic tool. It was, should I intervene and how? Is this patient progressing because they're actually having spikes outside the office that I need to address? But now what I'm finding, it's a monitoring tool. I have patients who have had stents, have SLT, have had Durista, have other interventions, have changed medications, and especially with my patients that own the iCare home, it allows them to follow their IOPs and also answer the question, What's affecting my IOPs? So how do I present home tonometry to my patients? Well, again, the borderline patient, the new patient that comes into the office that has some damage, maybe mild or advanced, I want to know, what is their true IOP? What is their max IOP? We ask them in the office, but again, it goes back to, we're going to treat off of that top number. Do we need treatment? There's been numerous times now where I've had patients come to see me where maybe there's some visual field defects, OCT changes, and I don't know if this is normal tension glaucoma or maybe something else. Does this patient have some sort of optic neuropathy, compressive optic neuropathy? Do I need to send them for an MRI? And finding out what their IOP is can actually really help us monitor and diagnose those patients, a lot of times in conjunction with our neuro-ophthalmologist. Post-procedure, SLTs. I think this is the hugest unmet need. At the VA, I have patients traveling 3 to 4 hours to come to see me after their SLT just for an IOP check. That seems like a huge waste of time, effort, resources, and especially inconvenience for the patient and loss of wages and struggles for their family who's driving them. So again, if it's just a quick IOP check, why can we not be doing that in the home? Why can we not provide these patients with the iCare home, get a week's worth of data, and be better informed about whether or not our therapy is working? Patients struggling with compliance. This is a great example. I had one patient actually who was using the iCare home. They missed their medications for 2 days because they were actually camping, and they saw their pressure spike up. So they knew that, yes, their drops were working, and it actually improved their compliance. Again, I mentioned normal tension glaucoma. That's the obvious. A lot of times these patients are actually spiking in the early waking hours. And I mentioned the SLT. So case studies. So this is a published paper. This was not my paper, but this is one of the first articles that had me scratching my head. Because how often do we blame progression on the patient? How often do we say, well, your visual field's getting worse. Maybe you're not using your drops as much as you should be, or you're not as compliant. This is a 72-year-old surgeon. You know he's compliant. He actually has exfoliation. This was a paper out of Simon Roy's clinic. And in the office, he was in the mid-teens. He was actually spiking to 43 in the early waking hours and 28. And this is what his IOP diurnal variability looked like. So this allowed them to actually go ahead and change the medications. So he went from brinzolamide and Vyzulta, they added Notarsadol, and it flattened the curve. And again, the same thing. So it definitely made a difference. Changing the medication made a difference. He could have progressed, and then they would have been saying, should we intervene or do something different? So it allows you to be proactive rather than reactive. This is my patient. And again, another XFS it just happens to be. But I think what's really interesting here is she never had high IOPs. She had some exfoliation in her left eye. Every time she came into the clinic, she was 16, 18, 17, 19. So essentially, I don't even know what normal is anymore these days, but essentially normal. Her OCT had some thinning, but she was a myope. Her visual fields were full. And we kept saying, should we treat? Should we treat? Yeah, the exfoliation. We know your IOP is going to go up at some point. On the top is her left eye in red. And you can see that she was actually creeping up into the high 20s. She actually hit 30, over 30, consistently in that left eye with exfoliation. But yet we were not seeing this in the clinic. Her right eye is in blue. So we did an SLT. What did it do? It brought down that diurnal variability to the point where it's almost superimposed on her uninvolved eye. And it was a great option for her because she really didn't want to do meds, but she didn't know if she needed treatment. So this allowed her to be informed, to make a decision that perhaps hopefully will save vision loss in that eye. Another patient, a 37-year-old patient with uveitic glaucoma. This actually came out of Wilmer. So I work really closely at Moran with Wilmer, and we've now put together over 400 patients. This patient was a 37-year-old gentleman. He had uveitis, and he had intermittent headaches. Every time he was in the office, high teens, low 20s, they wondered about his headache. He was actually spiking into the 40s. And he wasn't spiking, in this case, in the early waking hours. It was sort of variable. He was a steroid responder. His trabecular meshwork was probably very occluded. So they did a goniotomy. They did a GAT procedure, completely flattened the curve. So when we look at this, you know where the resistance was. The resistance was at the TM. And I think Jitham solved his headaches. This last patient is a patient of mine, a 67-year-old male. He was told of normal tension glaucoma for years. I ended up seeing him during COVID, actually. And again, he was supposedly controlled, multiple medications. His pressures were in the low teens, 12 to 14. These were his visual fields. So these are central 10s. He clearly has loss into fixation. And when we did the iCare Home, he was showing spikes into the 20s, which were way too high for this nerve. So we were able to intervene. Now, this gentleman actually owned the iCare Home. So we are able to get continuous information. So he had some cataracts. First thing we did an ABIC, so we did a cannuloplasty and a hydrus. So here's 20. Here's 10. It worked, lowered those spikes a little bit, but he was still fluctuating in the teens. And again, based on the visual field, we then decided to have him go outside the U.S. to get a PreserFlow in his right eye. This eye is off medications, and he runs between 8 and 10 after that PreserFlow. We have bypassed the outflow system, the trabecular meshwork, the distal resistance, and in the left eye is on medications, and you can still see that there's more variability. So why did I start my eyes? And this came up a little bit before, because I really thought there's a better way to manage patients. We as doctors, there's more patients, less doctors, more challenges to get patients into our office, less reimbursement, and we're literally overwhelmed at times. And if we can simplify things for ourselves and the patients and get really good, useful information, we thought that was a win-win. So how it works, patients work with their doctors. Doctors write the prescription at our website, and then we send everything to the patient. We educate the patient, we send them the device, and then we send the doctor the data. So with that, I want to thank you for your time, and I'm happy to take any questions. So the success rate for training the patients, and we get that asked quite a bit. We have patients that are in their 90s being able to use the device. And the team that we've put together, and I actually have some of our colleagues here from the company, really do a tremendous job educating the patients because they care. They care about the outcomes they care about, and they themselves know the value of the information. So yes, patients can absolutely use it. Some, need a Zoom, but a lot of them can actually do it over the phone.